I just had a conversation with a major hospital in our area, and they were making the case that we can't provide inpatient postpartum services because there's not enough outpatient providers then to refer them to after. The logic is a little skewed there, but they're like, why would we flood the system if there's not enough providers to even treat these women? And the reason I bring that point up specifically is there is so much to go around here. Turf war it all, or even comments in that vein of like, this is a PT thing, not an OT thing. That comes from a place of a lack of knowledge, that knowing that OTs can take these courses just as much as PTs through Herman and Wallace, and just a misunderstanding of the need, I think.
And Marley, just remind me, didn't you reach out, connect with me about your own capstone? And then we did that like panel interview with all the moms sharing their birth stories. Is that right?
Yeah, I honestly don't even remember how it started, but, or what my even initial question was, but we had a whole roundtable of clinicians and just participants in how their birth stories went and how we could use that information for the hospital setting. And that was part of my capstone project as well.
Okay. All right. I would love to maybe give a big overview of that. And then every clinician that's joining us today, we just go around and we just talk about um, capstones, professional experience, anything and everything that you can possibly think of that an OT and PT should know. And do want to say, just to kind of start, this off, I'll be managing people coming in and out, but this will be recorded and just shared with every student who wants to know it, for their capstone or for whatever, they're doing initiative wise. But then I'm gonna reference just a lot of interviews like that. Like Marley, your interview with me, that roundtable, I mean, that's out there for people to find, but that still gives me chills, some of the stories that we heard. And just that was all you, and I want you to take it from here. But I just did an interview with Dr. Addie Jeeves that is giving me goosebumps because I just finished editing it and putting it out there. And I'm like, every student has to hear this. Like, hands down, every student has to hear her interview. It was so good. She just published the first case report of its kind of physical therapy in the hospital after a C-section. So that's out there. We'll talk with her about that when if she's joining us. And Marley, if I could actually just pin you and spotlight you, can you share a little bit about your capstone, your professional experience, and anything that you feel that OTD students should know?
Yeah, absolutely. So I did my post-professional doctorate degree. I started that in 2022 and finished it in 2023. And I did that through Towson University and did my bachelor master's degree there and then went back for my doctorate and focused my capstone project on creating a maternal health protocol in the acute care setting. I work for a level 1 trauma center, so I wanted to incorporate OT as more of a routine consulting service for all postpartum moms on our birthing center. So once I figured out that's what I wanted to do, I just started doing a lot of research on what programs even existed out there, on how I could figure out if anyone was even doing this and what I needed to do. I joined some Facebook groups. There's a couple like OT and PT for OB patients, pelvic health for OT Facebook groups, and just asked that question, who works with these patients and how can I get started? And Rebecca's program, ERAD, was the main pinged one that said you need to take this course. So that's what I did. And through that was able to get connected to Rebecca, and Rebecca was able to connect me with other practitioners who had already got the ball rolling and starting these programs and learning from them as well. So with the combined continuing education through ERAD, doing some literature review research on other, countries that do these programs, what are pelvic floor dysfunctions and how does birth impact people's ability to function once they get home, took all of that information. I emailed the chair of labor and delivery at that time at my hospital and just said, here is my research. Here's what I would like to do. I'm an OT here at the hospital. I think my department could really benefit working with your patients. and she was agreeable. She was really excited about the idea and had me present everything that I had told her about at their grand rounds in the fall of 2023, which was in front of their whole department, every doctor, advanced practitioner, midwife, nurse, and gave them my whole capstone presentation basically after a year of research and continuing ed. And as part of that, as well, as Rebecca mentioned, I had emailed her and as part of the ERAG course, had to do a little bit of an in-service. And we turned that into a roundtable discussion of recruiting practitioners who worked in maternal health and just people, postpartum people, to ask what their experience was, both as a professional practitioner and as a postpartum person as well. And I think it ended up being like a 2.5 hour discussion. It was really long, and then we got so many, like, so much good feedback from it. A lot of unfortunate, traumatic birth stories, but that was really good info for me to then take to my presentations and to my doctors and say, these are what people, this is what people are going through, and this is how we can help. So that was really helpful as well. And yeah, asked for automatic OT orders for all C-section and vaginal delivery patients, and they loved it. And in 2024, that program officially launched, and I now see all postpartum patients within 24 hours after delivery if they're medically stable, and definitely before discharge if not.
I'm like feeling what Dr. Carpenter is saying in the chat. Absolutely. Advocacy is Marley's middle name. Can I say that, Marley? So I should say Dr. Sizzler. I mean, first of all, I do want to just shout you out again. And I did this in a closed group in the training, but it was because of you having those more maternal mental health and very sensitive cases that you would see in the hospital that made us do a pivot, reach out to Lindsay Vestal and Laura DeRozier, and bring them into the perinatal rehab training so that we can get more trauma-informed maternal health content. But you shared, cases that I'm sure that, students who are interested in the maternal mental health aspect of their capstone. That's why I ping you a lot. But if there's any students in the room who'd like to ask a question of Marley while Dr. Sizzler, while she's here, please ask specific to maternal mental health, um, acute care, obviously, occupational therapy. Dr. Sizzler, any physical therapy in your hospital, or is it OT led?
Yeah, so it's OT led right now. And if, but if we do have patients that are presenting with more physical, difficulties that I don't feel like I can cover, in my scope of practice, my providers are really quick to put in a PT consult, and that's no issue at all. I've been talking to one of my coworkers about, she is really interested in becoming more involved in that setting. She's specialized in doing some spinal manipulations, which I find a lot of people have issues with back pain after epidurals, and the labor beds are just super uncomfortable in general. So we've been talking about trying to get her more involved as a more routine consulting service as well, just to continue to do some, manual manipulations on people after delivery as well to get them back into alignment.
Prior to discharge,
Hmm.
postpartum discharge.
Yep.
Wow. Okay. Um, and Dr. Carpenter, please, I know that you're in the room. If you even have questions that you would anticipate maybe students in the future would want to know, please, I'm inviting any educators, any obviously professors, guest lecturers, anyone who is student facing, to really chime in and ask questions that you think your students or future students would benefit from. But that's pretty unusual, I would say. Dr. Sizzler, would you agree? Like spinal manipulations, I think that you even have pelvic health and pelvic floor training, internal pelvic floor training as well. And that's come up in conversations. Do you ever utilize those skills in the acute care setting?
I do, yeah. So I also did a course through to learn more about pelvic floor therapy, just because I felt like I wanted to be really well-rounded in what I was, doing for these patients and able to answer their questions. I don't do any internal techniques on people in the acute setting just because they're super acute and just had a baby. But I do get a lot of questions from moms about, well, I'm peeing my pants all of a sudden. I can't make it to the bathroom, and I have pelvic pressure now, or I have pelvic pain, or I've been dealing with back pain for a while and it's still, happening. I was hoping once I had the baby it would go away. What can I do about these things? And I'm able to confidently give them some resources and strategies to implement in this acute setting, because most pelvic floor outpatient therapists won't see postpartum patients until 6 weeks of recovery, which we're also trying to work on a little bit more, at least just advocating to trying to get them in the door if the therapists are willing to see them a little bit earlier. Again, nothing internal has to be done before 6 weeks either, but giving them something that they can work on until they're able to see an outpatient therapist as well. And I don't think you have to have, you don't have to be a certified pelvic floor therapist, but I do think you need some a training in what the pelvic floor is and how to answer some of these pelvic floor dysfunction questions so you're adequately able to treat people where they're at in this acute phase so they're not just stuck with trying to figure it out once they get home.
Awesome. Wow. Thank you so much for sharing. I want to invite other clinicians really in this discussion. And Dr. Sizzler, if there's anything that you feel like, oh, I'd like to add, I think, students, because I've sent a few students your way and you've answered, really just in more depth than I can. Please, anything that you're anticipating that students might want to know, just chime on in. But I'm going to invite Dr. Addie Javes to our discussion, Dr. Alex Myers, Dr. Aaron Samuel, which I'm so happy that you're able to join us. I really want to, uh, you know, share with your experience. But then a student who's actually reached out to me quite a few times, and I think I've connected her with you. So Diana Theodore, if you're actually with us and you're able to unmic or just ask your question, let us know. But I'm going to just add you on, and there might be others also.
Hi, hello. Hi, yes. So I saw in the chat, it's true, not many students know about pelvic floor therapy in outpatient or inpatient acute. And actually, some professors don't encourage pelvic floor therapy. They think it's too niche and we should be generalists. But I train as a doula and I've talked to many moms and coworkers. And in a doula training, I was in a group of 16 women and everyone wants to know, yeah, it seems like the most obvious thing. And even dads wonder too, why isn't therapy being offered to moms? It's because I met moms who 7 or 4 years after an episiotomy or C-section, they still have pain and discomfort. And my capstone is going to be in mental health, maternal mental and pelvic floor health. So that's what I'm going to be doing mine on. And yeah, it was a little bit of a push, and I'm very excited to be a part of this group right now because there's so much information and knowledge. And there are a
Excellent.
lot of students who would like to know, but they have no idea. They keep saying that they know. Everybody keeps telling us that, but that's for pelvic floor therapists. No, I mean physical therapists. Like OTs don't do this. It's only physical therapists.
Anyone want to tackle that? And is it Deanna or Diana?
Oh, Diana.
Diana, and you're an OT student, is that right? OTD? OT?
Yes, OTD. I'm going to do a capstone. Yes.
Excellent, excellent. Anyone want to tackle that? Yes, there's a lot in there. Students are either being told that that's pelvic health, therapy is not needed after birth that soon.
I would like to maybe not tackle that, but at least speak to that a little bit. I just had a conversation with a major hospital in our area, and they were making the case that we can't provide inpatient postpartum services because there's not enough outpatient providers then to refer them to after. The logic is a little skewed there, but they're like, why would we flood the system if there's not enough providers to even treat these women? And the reason I bring that point up specifically is there is so much to go around here. Like there's a turf war at all, or even comments in that vein of like, this is a PT thing, not an OT thing, that comes from a place of a lack of knowledge, that knowing that OTs can take these courses just as much as PTs through Herman and Wallace, and just a misunderstanding of the need, I think. And so, Diana, I would encourage you to go back to your professors and say, men, women, children, everybody needs this service at one time or another, and OTs are just as equipped as PTs if we have extra training, just the way PTs do, and maybe just kind of right the ship a little bit, just so then that they know that maybe they're not naysaying it to the next cohort, that they can encourage this interest that somebody has. Maybe they don't know the answer, but they can direct them in the right to the right place and at continuing ed to do that education. I don't know if that was coherent, but um, can I ask Diana, what university are you at?
Oh, St. Augustine in Austin.
Oh, wow. Okay.
But I must say I was very fortunate that I got my first rotation in a pelvic floor therapy clinic. It was hands therapy and pelvic. And this is an anomaly because they had the physical therapy side and occupational therapy side. And pelvic floor, they were getting flooded. They were trying to train quotas. Everybody was interested. They had weekly trainings because they couldn't keep up with the demand. It was near a military installation as well. And there were a lot of moms, a lot of people of all ages, and men as well coming in for therapy. And they were ashamed and embarrassed. But when they felt comfortable, they told their friends too, especially the new moms. And 12 weeks in, they said, oh my God, I can't believe I can laugh. I can do so many things without peeing on myself, you know? But it was a push, it was a fight, but I'm very happy that it did find a clinic for me to go to. And I think I got more pelvic therapy training on hands because it was so busy after a while on both sides, OT and PT.
Yeah.
And
Thanks for
Diana,
sharing.
I have a question because I do want Dr. Javes to just chime in. She was just speaking with me 2 days ago about this, about entry-level providers and why it's important for them to have the training to treat patients after major abdominal surgery, open abdominal surgery. Do you feel like you've had even adequate training in that, treating patients acutely from what you've learned in school after open abdominal surgery?
School, they don't focus on that at all. Not really. No. I know in the clinic, I had outpatient experience, which is different from acute. It's very different. So,
Right. So if you have a rotation or a field work in acute care, that's when you'll probably get more of those acute experiences. Is that right?
yes, but I talked to my university and they said that for one of Brian, they do have a contract for capstones with Brian. So maybe for capstones, that's a yes, but for regular field work, no, because they want it to be general.
Understood. Dr. Javes, can you speak to a little bit of what you typically, if you have the opportunity, even if it's a student that's not your student, if you do have the opportunity to, take them with you on the units that you serve on, what do you typically show them? What do they learn with you?
Yeah, I usually will bring students, and I mean I just bring them with for anything really, but I'll see them post C-section or a grade 3-4 tear or high risk pregnancy. And then the other things we typically would get ordered on would be postpartum, like uh any kind of pain, so like maybe like a nerve injury or something. So I honestly, my philosophy is that I try to expose students to everything because then they can see everything that we do, like our whole scope. I do find I have yet to have a student that has seen this before. I haven't found one that's just been like, oh yeah, I did this at my last rotation. I haven't found that yet, but so I do find that if they've been in acute care for a bit, the cesarean sections make a lot of sense to them because we're treating them like we would an abdominal surgery on the floor, obviously with some added education um and then the nerve injury ones or maybe the back pain or SI pain just kind of that pulls in more of like what some people call your outpatient mindset, right? So I try to show people that you can use all of the skills that you learned in your generalist degree, regardless of the setting that you're in. I don't know if that answers your question.
It does. And can you share a little bit? I had Dr. Sisler do this as well, but can you share a little bit about how you even started as an acute care PT treating on the maternity unit? That's a common question we get from students.
Yeah, my manager started this, so I guess was that was an easy barrier for me to not deal with, was I already had buy-in from my boss on this. I actually my I actually think that she started it just due to knowing more of the needs that can occur, like a grade 3 tear, or just all of the C-sections. Um, but we actually started a pilot program at my hospital where we would we're a teaching hospital, so we had teaching service. Any of their patients that had a cesarean section or a grade 3, 4 tear, they ordered us on those. And then we actually collected data for the first like 50 or so, where we had them all fill out like a questionnaire on like if it was helpful or not, or if we like it was basically like, oh, how satisfied are you with like your visit? Like, did you feel that the therapist addressed your goals? Would you recommend this to a friend? I think like for anyone who had a C-section or like in the past, it was kind of like, do you wish you had this on your first one? Like questions like that, just to get some general feedback. And literally all of them were all positive. Like everyone had all good things to say, like about PT. So like clearly we were helpful. So we took that data and then we brought it to, um, we basically presented that again. And then so then we kind of paired with the residents because they tend to assist our OBs on the C-sections a lot. So like not the teaching service OBs, but all the other OBs that come in and also do labor and delivery there. So then they started ordering it for all these other ones. And we are still in the process of getting it to be like an actual like a automatic order. We are really close, I think. Stay tuned. Um, but that's kind of how our program started. And then it honestly it just grows, I think, as you build relationships with the providers and the nurses and they understand what you're doing. So we've been doing that for I would say a little over 2 years now. But yeah, like I said, it's kind of started with me and one other acute care therapist. We've now grown to four. We don't have OT though, but I do love OT. They're my favorites. So
Well, and you did say that, Addie, you mentioned that a lot of your treatment sessions will range from 45 minutes to 60 minutes. Marley, is that the same for you?
Yeah, for the most part. And a lot of the treatment that I do is just a lot of education. I talk to people all day long till I don't have a voice at the end of the day because functionally they really are able to get around pretty well for the most part, with some limiting factors, a little bit of pain here, a little bit of soreness. We can talk about some postural things and body mechanics, but it really is just educating them on how to be able to apply everything we're talking about here and doing it at home when you have a 2-year-old at home and stairs and a laundry basket to carry and things to look out for in the next couple of weeks as well. So we may not even move that much, but we are talking the whole time. And I love it. I love being able to just answer those personal questions that for whatever reason, people are too scared to ask their providers. And it always blows my mind, like even just the medical questions that they ask us. And I genuinely think it's because we have the time to do it and we dedicate the time to do it. Unfortunately, the doctors and the providers, they're so busy and their schedules are just packed out every day, right? But that's why I love what we do. We have the dedicated time to get to know people and really address their concerns as well.
Yeah. And I mean, before I pull in Dr. Samuel, I wanted to just say something from the home health front. I observed an interview, it was an evaluation, pardon me, a virtual health evaluation with Catherine Sylvester and a mom who had hemorrhaged. to the point where the physicians were wondering on the table, do we do hysterectomy? Can we get this under control? Fortunately, they were able to get it under control, but the mom was 3 weeks at the time of Dr. Sylvester's virtual evaluation. And I observed the evaluation, and just like you're saying, Dr. Javes, Dr. Sizzler, there was so much speaking because there was still unpacking just the trauma of, the postpartum hemorrhage that this mom experienced, the, taking her vital signs and movement. And eventually she was able to get the mom out and walking and monitoring her vital signs with her mom holding the phone and making sure that the camera could still see what she was doing, all of that. It was such an interesting evaluation, a little over an hour or so. But not much more than that, but a lot of talking and a lot of education. And that's all billable time, just in case future students are just wondering, how do I bill for this? How do I, value this? Is this really valuable? We're not moving a lot. Sometimes in those cases, you don't really want or need to move a lot, but that person really does need to know um, what what to be feeling or what's normal or what's not normal. So that evaluation was really eye-opening. And there's opportunities for virtual health now, probably more than, especially when I was a student, 10 years ago, um, or a little bit more than that. But Dr. Samuel, if you could chime in, because you are unique in this situation where you don't work on the acute care unit of your hospital.
Yeah, so I
Welcome.
started from the outpatient perspective. Our program started with me being the pelvic floor physical therapist and seeing an opportunity. So I work at a small critical access hospital, so that's 25 beds or less. So we have two labor delivery rooms and we have less than 100 births per year. And I saw a need and an access issue and an education issue. So we decided to start there with me. And it was just me going up and talking to moms. And we started with high degree perineal tears, um, just as a place to start. And I quickly realized that if I wanted it to be sustainable, I needed to work with my colleagues, because I have a baby in my arms right now. So certainly I wanted it to live when I wasn't there. And also, I learned a lot as I went and realized that this is more than pelvic floor. This is acute care. And I took the ERAC course, and learned a lot about what else I could be doing for the moms that we were seeing. And we trained our PTs and our OTs, everybody who was interested, which was pretty much the whole department, including some of our male PTs, um, who were super excited to be involved with the program. And um, yeah, we bring students up. I think it's one of the unique things about a critical access hospital is that we do get to see a lot. We have our med surg unit, our ICU, and we have what the women's services or labor and delivery. And we, just like Addie was saying, we try to expose our students to everything. So everything that I do, we bring them along for the ride. And again, it's usually very unique. We haven't had a single student who's had this experience as well. But yeah, it really has evolved because we realized quickly that it's not pelvic floor physical therapy. It's physical therapy and occupational therapy. Now we have automatic orders for PT and OT, and we send whoever's available first up. So because we're coordinating mostly outpatient therapists, so really trying to find who has time in their schedule that coordinates with the discharge planning. And they'll go up to the floor and see the new mom, and schedule that with nursing and really try to make that work for everybody. And we've seen in the past 6 months, 82% of the moms. And we struggle, we don't have weekend services. So there's been some struggles that we've encountered, but overall it's been really successful, and having students has been wonderful for it as well.
Awesome. Thank you so much. Thank you. That is such great information. I want to kind of bring this round full circle with Dr. Myers. If there is anything that you'd like to just pass on to students who are just really passionate, interested in this area of practice, and we're really speaking about acute care. And I would even like echo with what Aaron was saying, is that even in the outpatient setting, up to the first 30 days, 60 days, or 90 days, that's still considered very acute for this population. And still kind of within the realm of that period where they could be sent back to the hospital if there's complications, or that period of time where they're not always able to access an outpatient therapist. I knew that I had a 3-month wait list when I was practicing full-time outpatient pelvic health. And so I just wouldn't have seen this patient population had I known what I knew now. And so, Dr. Myers, if you can maybe anticipate questions that students may have in the future that this type of roundtable discussion may be helpful for, what would be some advice or takeaways that you can give to them?
Um, I think the main takeaway is that if you have the interest, explore the interest, right? I think it's so wonderful that people have already reached out to you, Dr. Seagraves, and Diana, and I know one of my students at Eastern Washington University has reached out to you a few times, well, in the PG department. So that would be my first advice, right? Like follow your passion, follow your interests in this field. I mean, that's going to take you so far. You can't fabricate interest, right? And so follow that scent first and foremost. And then if you get some no's along the way, which you might in the OT world specifically, look to the people that are doing what you want to do and reach out. There's a huge community out there that can be found on Facebook, or if you reach out to somebody like myself or Dr. Seagraves or anybody in that world of pelvic health and your discipline, get encouragement and make contacts and build your network. It's all very possible, and it's all very possible in every setting, specifically acute care. I mean, I really can't drive home the point of this conversation I was having earlier with the hospital that was very resistant to making any amount of therapy not even an automatic order, just going in there in general in the mom baby unit. And it's just there's a lot of resistance out there, but keep pushing. I think you said it best, Dr. Seagraves, that it's like these are all about relationships. Once you have your foot in the door, you build the relationships, whether that's in an academic setting or professional setting. Talk to people, show them your interest, show them your knowledge, and you're going to have doors open for you, I think. Yeah.
And Dr. Myers, can you end with where you're from, where you're practicing, your background?
Yeah. Yeah, absolutely. So I'm in Eastern Washington, in Spokane, Washington. It's a smaller town. We're the second biggest city in Washington after Seattle. I work at Eastern Washington University as a full-time faculty member, and then I also work as a pelvic health clinician in both the acute care setting and the outpatient setting. Per diem. So I don't have three full-time jobs, full-time faculty, and then 2 PRN jobs. So, but I love this, keeping my feet in the continuum of care and seeing how it all works and seeing what changes we can make. There's so much opportunity for growth and access. So,
So
yeah,
I'm
I'm
hearing you're
happy.
not busy at all.
Not at all. No,
No,
no, not
no.
at all. None of us are, right? Yeah,
Right.
we're
Awesome. Dr. Sizzler.
Yeah, I was gonna say I can piggyback off of that a little bit just from the OT perspective too. So when I initially talked to the co-chair of OB about this program, she said that I guess a couple of years ago they did actually have a PT that, would kind of work with patients on the unit, not I don't think routinely, but pretty frequently. And she said, I am actually really embarrassed to say that I didn't even think OT could even do this. Like the thought of an OT doing this never even crossed my mind. And she said, I'm embarrassed to admit that. And I was like, it's okay. I mean, you guys aren't taught what we do in your medical training, just like I'm not taught how to be a doctor in OT school, but it's cool that this relationship is starting to build. And especially from an OT standpoint, I feel like we just have so many avenues that we can go down. I often call us like the unicorns of therapists because there's just so many different things that we can do. So especially for capstone students, if you have any interest in anything maternal health, there's just so many ways you can go. Maternal health and mental health is a big one. Diana, I know you said you're incorporating that into your capstone. I found so much research about the correlation of pelvic floor dysfunctions that impact your mental health and how that really plays a part in your daily activities as well. OT and lactation, OT and maternal health and like birth prep and postpartum prep. We're kind of starting some talk about how we can start to get to moms better before birth and continue working with them after birth as well. So, like Dr. Meyer said, if you have an interest, just go for it. And if you are able to find someone that works in that field, talk to your professors and see if they'll come do a guest lecture as well, just to talk to your class and tell your class about what they do. And then hopefully that can eventually lead to some curriculum being built into these academic programs as well, which I talked to Lindsay Vestal recently. She's OT Pioneers, and she's trying to get that more integrated in OT curriculum as well. So I did that at my university, and I was happy to do it just to give some introductory info.
This is pure gold. Dr. James, anything you want to leave for especially physical therapy students that you've shadowed? Any words of advice, encouragement, things you want to pass along?
Yeah, I mean I would definitely echo what Dr. Sizzler said there, where if you're interested in that field, like talk to your DCE and see if they know any contacts. I know a lot of times like the DCs that we're in touch with, we try to let them know, hey, we've got like more specialized or like rare programs where we're at. Like, so for example, I'm also in the emergency department. So like if a PT student's interested in that like weird little area of PT, they know that there's like a placement in that realm at our hospital if they want to do that. Um, I would say the other thing for PT students is just like I would, when you're setting up, or even when you're at your clinical, even asking, regardless of the setting that you're in, especially if it's like a hospital system, you can always ask, like, let's say you're doing outpatient, like an outpatient rotation, but it's part of a hospital system. You can ask your CI if they have this program on the inpatient side and if you can go shadow. Like we do that sometimes where we'll flip students between the outpatient and the inpatient just to get them an exposure, a different experience that they wouldn't normally see.
That is super cool. I did that on an outpatient rotation, but again, it was for orthopedics. So I saw a lot of knee surgery in the hospital. And strangely enough, that's probably why I use knee replacement as such a big example, but I just fell in love with post-surgical care. And a lot of people thought that was like boring, didn't want to get into that, but I really have found a lot of parallels with the post-surgical population, with the maternal population. Obviously, we talk a lot about C-section, but just parallels in general. Just first time getting up, fall risk, all of it, and yet they're sent home with a baby and sometimes even wheeled down right to their car, and so we really never get to see them walk those long distances. So for students who are even interested from an outpatient perspective, what are things going on? Dr. Samuel, I want to end with you because you do offer something similar to Dr. Javes that she was just saying is that if they may have an outpatient rotation, perhaps they can be pulled in and see what care looks like for the maternal population during their hospital stay. But if you could give maybe a big overview for those students who are just interested in more of the pelvic health, big picture, how do I get more experience with this population in general, what would you say to them?
Yeah, I would recommend them having an open mind and again, just being really open to taking advantage of all the opportunities that wherever their rotation has to offer. So again, if they're in a hospital system or a small hospital like ours where it's embedded, small outpatient clinic, but there is an acute care service to not only be open to those experiences, but really, again, seeking them out and seeing what all you can learn and all of the different professions too that you can learn from. I know that we often have our PT students shadow with our OTs for a day or shadow even with our speech therapist so that they can see that perspective to really have an understanding of that scope and that lens that they're looking through. And yeah, just have an open mind really and just be excited to learn and not to be discouraged too if you end up at a rotation that doesn't have this. If this is an interest for you, and there are so few hospitals at this point that offer this as a service to still take advantage of that rotation and then maybe use this as an opportunity to have an in-service for that group about what you're interested in, why it might be valuable, and use that as an opportunity to educate, to spread the word.
And every OT and PT student has to give an in-service at every fieldwork placement. Is that right? Dr. Myers, you're shaking your head. Diana, is that right? You've had to give an in-service.
Yes.
Right. Excellent. I think that's great advice. Well, I want to thank you. I probably should bring this full circle with even myself, my own story. So that now students that are reaching out to me, they want to know how I got into pelvic health and maternal health. And my story is probably in a lot of different places. But where I want to probably focus on now is really what I'm doing now, is that I think that telling the story of the journey is just as important of getting there. And who knows, in our lifetime, in our professional lifetime, at least in our careers, if we'll see a time where at least the post-surgical population is getting the same access to OT and PT. And I've been on that soapbox for a while now, but even after a major abdominal delivery, moms are walking around fine. I'm going to link to this video on YouTube, the interview that I just did with Dr. Jays, because even though it was a 35-minute video, I think I watched that 3 times all the way through. It was just that good. And she's like shaking her head, like, I don't really understand how you think. But the things that she said in it were just so true, is that we just look at that individual, if they're able to walk. Most likely in acute care, we're kind of deeming them as more of a lower priority than someone, obviously, who can't get out of bed. And that is absolutely understandable, except I've been on the side as an acute care therapist on the maternity unit of those patients being readmitted back to the hospital, and us just catching or not catching something that we could have possibly avoided, as in a brain bleed that our team treated from a patient who suffered a hemorrhagic stroke after birth, after cesarean delivery, and then other issues like postpartum preeclampsia that got them back to the hospital, or cesarean incisions that split open and then turned into sepsis. And so I've seen a lot more of the high risk complications related to maternal health, and have looked at ways to really reduce a lot of the maternal mental health complications that really come about that months and years down the road. And so I really enjoy now bringing experts like you all together, and especially connecting you with students, because I think students are just on the frontier of a massive change that we're going to see in women's health, maternal health, pelvic health, and really our fields in general. Telehealth has a lot of promising opportunities as well, and a lot of moms can benefit from even that interaction or face-to-face interaction, or having someone ask a few more questions than maybe their provider would at a 6-week postpartum visit. And so I'm really excited about where this field will go. And I hope that this interview, panel discussion, clinicians sharing their experience, and Diana, you as an OTD student, just sharing your observations and your passion for this work, I think it's going to help a lot of people. And so I can't thank you all enough for sharing your time. Thank you all.
Thank you for organizing this, Dr. Seagraves. Yeah, it's been cool.
Thank you for having us.
Thank you.